I'm glad to be here. It's sort of funny, I'm giving this talk today, and I think I gave this talk to a different audience around the same time last year or the year before. So I have these slides to talk mainly about gender and sexuality in children and adolescents. But certainly if people have questions, I'm happy to kind of go off script for that a little bit. So I've titled it Everything You Ever Wanted to Know About Gender and Sexuality in Gender and Adolescence, but We're Afraid to Ask. So don't be afraid to ask. First off, I don't have any conflict of interest. The learning objectives for this talk are about 6 of them. First, to know who our LGBTQ identifying children and youth are and what risks are commonly found among individuals in this population. To be able to define and distinguish between sex assigned at birth, gender identity, and gender expression. To be able to define and distinguish between sexual orientation, physical attraction, and emotional attraction. To have a general understanding of the natural course of gender identity development based on the literature that we have. To have a general understanding of the pharmacologic and surgical interventions used for gender affirmation and when and in whom they're appropriate to be used. And then finally, to know where to find help when you're working with LGBTQ identifying children and youth. And these can also be applied to young adults and adults in sort of a general sense. But again, specifically, I'm talking about kids and teens. So let's talk a little bit about who these kids are. Formal studies on gender dysphoria in children, adolescents, and adults are pretty lacking. Although there are more now than there probably were, let's say, 10 years ago. But some data from the community based on a 2012 study of 433 individuals. So if you look at the figure and the figures that are going to come up, the blue boxes are the numbers for trans youth with supportive parents, and the gold or yellow boxes are for trans youth with unsupportive parents. So just to say upfront, having supportive family makes a huge difference in terms of the quality of life of kids who are on the spectrum of LGBTQ+. They have greater life satisfaction. They have better self-esteem. They tend to not face housing problems. So roughly 320,000 to 400,000 LGBTQ youth faced homelessness in the United States annually. And given the pandemic and everything else, those numbers are probably higher or at least consistent. 40% of homeless youth are LGBTQ identifying. 68% of homeless LGBTQ youth have been rejected by their families, and 54% have experienced abuse by their families. If you look at this lower figure, in addition to that, 80% of trans students feel unsafe at school because of their gender expression. So for those who have socially transitioned, and we'll talk a little bit more about what that means. More than half of gender non-conforming students have experienced verbal harassment in the past year because of their gender expression. And then 49% of trans people reported physical abuse in a 2007 study. So they're kind of getting it from all sides, at home and at school, particularly if they have an unsupportive family. Supportive families can also make a significant difference in how these kids are treated at school. Having a family or parent that can advocate for you can make a huge difference. Now, what about their mental health? So the umbrella under which in psychiatry we describe kids who are struggling with gender identity primarily is gender dysphoria. It used to be gender identity disorder in other terms in the long ago times. But we call it gender dysphoria, which is the discomfort or distress caused by a discrepancy between a person's gender identity and their sex assigned at birth, and associated gender role and or primary and secondary sexual characteristics. So it's a sense of my insides and my outsides don't match. They're not telling a coherent story about me. So again, with the blue boxes being kids with supportive families and the gold or yellow boxes, kids who aren't. More than 3/4 suffer depression in the absence of supportive family, and more than half will have suicide attempts. So it's also extremely high risk in the absence of parental support. or at least guardian support, I should say, whether it's parent or not. So this is a graphic I love. It's from transstudent.org. It's the gender unicorn. There used to be the genderbread person, but I think the unicorn felt more sparkly and friendly. It's a really nice graphic to use to help people understand some of the differences between these terms, and it illustrates, I think, really nicely that these things are on a spectrum, that it's not just so much that you're this or that, but you can be a little bit of this, a little bit of that. It's a bit more of a gumbo than a bisque. So we'll break it down a little bit. So sex assigned at birth, gender identity, and gender expression. So what I like about this is, again, for gender identity, you can identify as female, male, other genders, and you don't have to just pick one. You can sort of slide the little slider along and sort of pick how much or what amount. Same with gender expression, where you can identify as being feminine, masculine, something else entirely. But it's also important to kind of bear in mind sex assigned at birth. That's when you're born, a doctor decides based on looking at you from the outside, unless they have some genetic information ahead of time, what your sex assigned at birth is. So they kind of pick for you whether you're female, male, or intersex. And as you may or may not be aware, there's just been a huge, over time, there's been increasing controversy about assigning sex at birth for people who are intersex. And typically the decision has been to assign those people as female at birth. Now it's more often the case where they'll wait and allow the child to kind of figure out or determine kind of how they identify without making any kind of surgical interventions. So what do these terms mean? And that just jumped ahead for me. So AFAB and AMAB. So the acronyms mean assigned female or assigned male at birth. Can also be a designated female or male at birth, or female male assigned at birth. So nobody gets to choose what sex they're assigned at birth, basically. As I was saying, the term is preferred so it's preferable to use the term assigned at birth as opposed to biological male or female bodied, natal male or female, or born male or female, given that it seems defamatory and it's not accurate, because it's something that somebody decided for you. Intersex is a person with a less common combination of hormones, chromosomes, and anatomy that are used to assign sex at birth. So it makes it harder for the person who's doing the assigning to make that designation. Examples are Klinefelter syndrome, where folks will have 2 X chromosomes and a Y chromosome, androgen sensitivity syndrome, and congenital adrenal hyperplasia. Then sort of basic terms, cisgender. Cis is a term for someone who exclusively identifies as their sex assigned at birth. It has nothing to do with one's gender expression, their sexual orientation, their hormonal makeup, their physical anatomy, or how they're perceived in daily life. It's literally just, I identify as the sex I was assigned at birth. Transgender encompasses many gender identities of those who don't identify or exclusively identify with their sex assigned at birth. And again, it doesn't tell you anything about how someone expresses their gender identity, their sexual orientation, their hormonal makeup, physical anatomy, or how they're perceived in daily life. So cis and trans is Latin. And anybody who's in med school did organic chemistry. So cis is when you have 2 of the hydrogens on the same side of a double bond, and trans when they're opposite. So if that helps with the language. So gender identity expression beyond the binary. This is a great, it's actually an interactive on this website, impactprogram.org, the gender map. It has a beautiful set of slides that kind of go into these things in greater detail. But what I like about this, the image of it, is it goes beyond sort of you're this or you're that. It's sort of there's so much variety in terms of how people can identify in terms of their gender and how they can express it. And we'll kind of dive into some of these things in the next slide. So let's see if I skipped anything. No, good. So gender non-conforming, non-binary, or gender queer identities. So what do all those terms mean? Because you'll hear them in different combinations and depending upon your audience or the folks that you're talking to or working with. Gender nonconformity is the extent to which one's gender identity, gender role, or gender expression differs from the cultural norms for people of a particular sex. So how are you different from the culturally accepted role that you're supposed to be playing? Non-binary is a preferred umbrella term for all genders other than male, female, or woman, man, and it's used as an adjective. Not all non-binary people identify as trans, and not all trans people identify as non-binary. It can also be used to identify or describe the aesthetic presentation or expression of a cisgender or transgender person. So these terms can be used pretty flexibly. Gender fluid, we often will see this actually in a lot of our kids, sort of a gender fluid, a changing, non-static gender identity where it really kind of can be situational. It can be how somebody feels during the day. So that makes it really important to know kind of how to talk with a gender fluid person, how you're going to talk about them if you have to. And we talk about pronouns in a little bit. Now, gender queer, it's an identity that's commonly used by people who don't identify or express their gender within the gender binary of male or female. They may identify as neither male nor female. They may see themselves as outside of or in between the binary gender boxes, or they just may feel restricted by gender labels. Now, many genderqueer people are cisgender and identify with it as an aesthetic, that's sort of in terms more of their expression than in terms of their gender identity. So again, not everyone who identifies as genderqueer identifies as trans or non-binary. So what are some other genderqueer, gender nonconforming, and non-binary identities? So it's more than just, these sort of larger categories. So there are people who identify as being bigender. Those who identify as two genders, they can also identify as multigender. This is different from being two-spirited or third gender. Those are associated more with First Nations cultures. A third gender, I believe, is more associated with subcontinental Indian cultures. Now, agender is an umbrella term that can encompass many different genders or folks who commonly do not have a gender, or they have a gender they describe as neutral. Many are trans, but not all. Basically, when using this kind of terminology, you should probably ask how the person defines it for themselves rather than making any assumptions. And I think over the rest of the talk, that's generally the take home is if when in doubt, ask and let the person tell you how they identify, what pronouns they use, etc. Now, androgyny or being androgynous is a term that describes gender expression that has elements of both masculinity and femininity. So that could be considered in some ways a genderqueer gender expression. Pronouns are important. And as I said, the best way to sort of figure out what pronouns you should be using is to ask the person, what pronouns would you like me to use? And I saw at least one person I can see has their pronouns in their name on their Zoom title, but you may see that with people's signatures on their emails and other things. So the traditional pronouns, again, he, him, his, she, her, hers, it, its. I will say that I've never, say it could never happen, but I have not personally experienced someone whose pronoun of choice was it or its, but certainly they, them, theirs is common. There are also some alternative pronouns that I've not seen most people use, but they're also there. So Z or Z, here, hers, I am heirs, Z, zer, zers. But again, the best way to know how to describe or write about a person or talk about a person is to ask them what pronouns they want to use. So sexual orientation, physical attraction, and emotional attraction. So physical and emotional attraction are different things and they can be uncoupled from each other. And again, sexual orientation, again, how you identify who you are attracted to. And as this, again, this is part of the gender unicorn picture, that you can have things on all three of these sort of spectra. Okay, moving on to gender identity development. There's been a lot of work, predominantly mostly in the Netherlands and sort of Scandinavia, where they have all these wonderful longitudinal groups like of data, these wonderful data sets, and they can follow people forever. And what some of this work has sort of pulled out is this this model here in this image. So what they found is that for children who identify as non-conforming prior to puberty, once they hit puberty, they tend to sort out in this kind of way. So children who identify as gender nonconforming, about a quarter will persist or continue to identify as being transgender through puberty and on to late adolescence. And the rest, the 75%, may identify as some variety of sexual minority youth, genderqueer or heterosexual, but they effectively are no longer identifying specifically as gender nonconforming. So what do we call these folks? So a persister. So a persister is a teenager whose gender dysphoria in childhood persists with the development of puberty and secondary sexual characteristics. And again, it's about a quarter of the kids who identify like this in childhood. These folks most often will have a stated desire that is persistent, it is consistent, it's reproducible, to be the opposite or other sex. And that can include statements of rejection of physical characteristics of their biological sex or aversion to stereotypical gender roles. More often, their gender dysphoria is associated with the longing for a different body. So for example, it's not just that they don't like the kind of girl they are, they don't find the body that they're developing as a female person, for example, to be their body. And they wish that the body itself was different. Desisters. So these are teens whose childhood gender dysphoria desisted once puberty began. And the overwhelming majority of kids with gender dysphoria will report desistance of their gender dysphoria, and kind of how they sort out will depend on the degree of their distress. And that will also tend to get better as they go through puberty and young adulthood. Most of those kids will identify as sexual minorities later in life. So they may not identify as transgender, but they may identify as other parts of the LGBTQ+ umbrella. So what do you do when you're working with folks who are under that umbrella of the LGBTQIA+? So as physicians, our main thing is we take histories, we document histories. And so to get people to tell us their truth, we need to, establish an alliance with them and have them feel comfortable talking with us. And so there's some simple things that you can do. Asking what name that they would like to be called by, whether that's the name that they were given at birth, whatever it is, what would you like to be called? Again, what pronouns do you want me to use? A sub question to that is, what do you want me to use in the office or in, when I'm meeting with you on rounds, versus what you want me to use in the medical record. For children and teens in particular, parents still have access to a lot of our documentation. So they may ask for us to use their pronouns and ask for us to use the name that they prefer in the office or on rounds, but would like for us to document their sex assigned at birth and their birth name in the medical record. And that's something that it's worth having a discussion with people about before you document, and making sure that you're maintaining confidentiality, because the last thing that I think any of us want is to expose someone to harm because of something that we did that we could easily avoid. When we're asking about sexual orientation, attraction, things of that nature, when you're asking people about the kind of partners that they would have or they have had, there are a couple different ways to ask this. The one that I typically use is, do you have sex with boys, girls, both, neither? A more technical, clinical way to ask would be, do you have sex with persons who have a penis, have a vagina, or both? Not necessarily both a penis and a vagina, but do you have sex with both of those folks who have either? Again, trying to meet the person where they're at. So for somebody who's a younger child, asking the question of, do you feel like your outside body doesn't match who you are inside? For instance, well, you were born a boy, but do you feel like you should be a girl? Sort of, again, making sure your language is not over the head of the person that you're talking to. And again, what sex were you assigned at birth? So other things, considering gender expression, where someone can be transmasculine, transfeminine, androgynous, and can still, be cisgender. They just may express themselves in a more transmasculine, feminine, or androgynous way. But these are all parts of trying to get to know the person that you're working with. These also work for people in your daily life. If you do have folks who you want to make sure that you're honoring that. Okay, so what do you do for gender affirmation? And I'm using gender affirmation. It used to be called gender confirmation, sex change operations. These are all, gender affirmation is, I think, what we're currently calling it, because it's really just affirming what people generally know to be true about themselves. So I mentioned social transition. When we think about kids getting bullied in school for gender identity issues, it's generally when they start to attempt a social transition. And what that is an adoption of cross or other gender role in all situations, including name change and use of opposite or other pronouns. So dressing in expressing your gender that is consistent with an opposite or other gender role. Although, as you can certainly guess, based on what I talked about earlier, you don't have to do that either. It's more that you are, I guess what people have said is you're out to people about how you identify in terms of your gender identity. Your gender expression doesn't necessarily have to change. What are some psychosocial interventions once you've got a kiddo who wants to socially transition? And even if you have an adult who wants to socially transition, or they're ready to do that. So in terms of things we can do before we get to more technically medical interventions, reduce gender dysphoria through cognitive and behavioral strategies. So therapy. Redirecting the child to neutral gender expression while enhancing adaptive ego strengths. So rather than insisting we're going to go 100% all the way, why don't we see where, we'll do this slowly. That can be frustrating for some kids who want things to be different tomorrow. But the recommendation is not necessarily to jump the gun and to kind of see where things lie. Facilitating egosyntonic social transition prior to puberty. So again, making sure that there is less dysphoria by having a supportive family helping one to do this social transition piece. Facilitating parental acceptance and assist parents with understanding and developing tolerance, if not acceptance and sort of, joy of the ambiguity of the child's trajectory. So that goes back to that figure about persistence and desistance. So helping parents understand that if in your prepubertal child, the trajectory tends to be this. So the majority of kids are not going to continue with gender dysphoria and sort of an alternate gender identity from their sex assigned at birth. But they may. It happens in a quarter of these kids. And again, educating the school to support the child and minimize victimization and bullying. And so much of that is going to be through education. In teenagers, that's when you start to think about, some folks who have gone through puberty, are in the process of going through puberty. So that is when it's appropriate to start having talks about medical and other non-invasive interventions to facilitate a social transition. For example, voice and communication therapy to help folks develop verbal and nonverbal communication skills that make them comfortable with their gender identity. So working on pitch, volume, tone, body, how you display or express your gender in your nonverbals. Also hair removal through electrolysis, laser treatment, or waxing, breast binding or padding. There's apparently some increased controversy about whether or not to use binders. And I had a kid tell me just yesterday, I think, that they were looking to get trans tape to help with breast binding, genital tucking, penile prostheses, padding of hips and buttocks. And then probably the biggest piece, and often the one that's the most challenging, is to have people change their name and gender marker on identity documents, although I think that is getting easier in some states and locales to do. So on to medications. What do people do? So they come in sort of gradations, things that are fully reversible, things that are partially reversible, and things that are completely irreversible. So puberty blockade is the fully reversible one, by which I mean puberty will happen if you stop the blockade. Are there changes that are hard to undo? Still, yes, but it doesn't interfere with the person's sex assigned at birth puberty course happening as it should. So adolescents can be eligible for puberty suppressing hormones as soon as they start having pubertal changes. The recommendation in terms of treatment is that teens experience the onset of puberty to at least Tanner stage 2 in terms of breast development. Some kids can get there at very young ages, 9 years of age, and we certainly see that more often now. There's a lot of precocious puberty depending upon the population of kids you're working with. What this does, puberty blockade, is it gives teens more time to explore their gender nonconformity and other developmental issues. So essentially, what it does is it helps social transition because it prevents development of sexual characteristics that are difficult or impossible to reverse if teens continue on to pursue their gender confirmation or affirmation. You can continue suppression. It's for a few years. And at the point where the decision is made to either discontinue hormone therapy or to transition to a feminizing or masculinizing hormone regimen, you stop the blockade. It does not inevitably lead to social transition or to gender affirmation. It really is just a pause. So how do you do it? There are gonadotropin releasing hormone analogs that block estrogen and testosterone, and they will delay physical changes of puberty. Medroxyprogesterone can also be used, spironolactone, which decreases effects of androgens, and then there are continuous oral contraceptives to suppress periods. One of the most common ones that I'm aware of people using is Lupron. People can get a Lupron implant. You can also do injections, and that essentially blocks all of these effects. So as I mentioned earlier, so neither puberty suppression nor allowing puberty to happen is a neutral act in terms of social transition and gender affirmation. Functioning later in life can be compromised by developing irreversible secondary sexual characteristics during puberty and by years experiencing intense gender dysphoria because of that development. On the other hand, there are real concerns about negative physical side effects of blocking gonadotropins, particularly on bone development and height. If you're blocking estrogen, it's bone development, height is going to be testosterone, so you can lose some height. This is why kids who are getting Lupron, for example, will need to have DEXA scans and things like that on the regular. So what's partially reversible? So that would be cross-gender hormone therapy. So many, but not all, and I think that's also critical, that not everybody does this or gets to this point or wants to go to this point. Many, but not all gender dysphoric teens have a strong wish for hormones and surgery, and they may be eligible to begin feminizing or masculinizing hormone therapy. It is preferable with parental consent. It depends on the country. In many countries, primarily again, sort of like the Netherlands, Denmark, Scandinavia, 16-year-olds are legal adults for medical decision-making, and they don't need parental consent to start hormone treatment. In the US, I believe they do. Pretty much all over the town, I think. But I'd have to look and specifically kind of figure that out. So someone, if that's the case, that you have a teenager who wants to start hormone treatment, it's helpful to kind of help them navigate the legal issues too. Now, some hormone-induced changes may need reconstructive surgery to reverse the effect. So if they're on estrogen therapy, gynecomastia may require reconstruction. Some changes are not reversible. So if you are assigned female at birth and identify as transgender male, testosterone can cause deepening of the voice that is not reversible. Now, how much is too much? How much is enough? How do you define it? Some people will seek maximum feminization, masculinization, and others experience relief of their dysphoria with a more androgynous presentation. So minimizing their existing secondary sexual characteristics is enough that they no longer feel that their body is a mismatch of the inside and the outside. That's what they need. And some people have a need to push it as far as it can go. And those are both fine. So what happens? So in patients who are assigned female at birth with testosterone, deepened voice, there's variable clitoral enlargement, growth in facial body hair, cessation of their menses, atrophy of breast tissue, increased libido, decreased percentage of body fat compared to muscle mass. In assigned male at birth patients with estrogen therapy, they get variable amounts of breast growth, decreased libido and erections, decreased testicular size, and increased percentage of body fat compared to muscle mass. So, gender affirming surgery, what people have historically called sex reassignment surgery, et cetera, et cetera. I think, again, the take home point for surgery is not all trans people want surgery, and even fewer get it for a number of reasons. These are irreversible. So surgery to change primary and or secondary sex characteristics, for example, breasts, chest, external and or internal genitalia, facial features, and body contouring. So one of the sites that I cite pretty much throughout this entire talk is the WPATH Standards of Care. And this is an international body that deals with regulating or kind of providing guidelines for how we as physicians should work with folks who are transgender. And these are sort of how their standards of care. So genital surgery should not be carried out until 1, patients reach the legal age of majority in a given country, and 2, patients have lived continuously for at least a year in the gender role that is congruent with their gender identity. They are very clear to say that the age threshold should be seen as a minimum criterion, and it's not an indication in and of itself for active intervention. So just because someone turns the legal age of majority, there's nothing magical about that. It really has to be on a case-by-case basis. Now, in terms of when surgical interventions can happen, chest surgery in assigned female at birth patients could be carried out earlier, preferably after a time of living in the desired gender role and after 1 year of testosterone treatment. Essentially, the reason to defer the surgical interventions, not just because it's irreversible, is it gives teens sufficient time and opportunity to experience and socially adjust to whatever their gender role is, desired gender role, appropriate, affirmed gender role, before undergoing irreversible surgery. Now, I have had in my training, I had a young assigned male at birth lady who was going to have bottom surgery, and I think she was quite young. I think she was 16, and that was pretty surprising to me, but I think she already was planning sort of the facial contouring. In general, breast chest surgery requires 1 referral from a qualified mental health professional, and genital surgery requires 2 referrals. So with that person, that patient of mine who was going to have bottom surgery, so having to do with recontouring, reshaping their genitalia, there was a lot of concern that her mother had that her diagnosis of her mental illness was going to get in the way of that. And as long as people are being treated, there's not a reason or an indication that they should not proceed with surgery, particularly given gender dysphoria can be so damaging to folks. So where do you find help? How do you help folks? So the American Academy of Child and Adolescent Psychiatry does have a practice parameter. You may notice it's from 2012. There's been a significant push to improve and update all of our practice parameters, but the last time I looked at it, this was 2012. So the recommendations are to always perform a complete diagnostic evaluation, consider confidentiality and family dynamics in the context of youth, family, and community cultural values. Ask about the circumstances that confer increased psychiatric risk, and aim to foster healthy psychosexual development and protect full capacity for integrated identity formation and adaptive functioning. So that everything should be seen through the lens of how do I help this person function most effectively so that they can live the life that they want to live. Of note, there is no evidence that sexual orientation can be altered through therapy, and attempts to do so may be harmful. So there's nobody in the psychiatric field at large or in psychology who supports conversion therapy, which is what it's called colloquially. It doesn't work, and it can be highly deleterious to both the individual who is being forced through it and to their family dynamics going forward. Be aware of the evidence in the natural course of gender discordance and psychopathology when you choose treatment goals and their modalities. So again, kind of what's the natural course of gender dysphoria in a prepubertal child? Again, it's going to be about 3/4 are going to desist and about 1/4 will persist. Being prepared to liaise with other providers, schools, and community agencies, and to advocate for patients and families. So being able to provide that kind of psychoeducation and awareness of community and professional resources for patients and families. Like, how do you help people go where they need to go? So there are some general resources, and I think you have access to this slide set. Gender Spectrum is a great one. Like I said, that's the one that has the gender map on it, I believe. No, that's impactprogram.org. Anyway, Gender Spectrum is also great. There's the LGBT Health and Development Program at Northwestern, which is the impact program, and that's where the gender map is. Genderdiversity.org. There's a great resource center at UC Davis EDU on LGBTQIA. And then their trans student education resources at transstudent.org. All great. And a lot of them have really great graphics. Local resources. So I haven't checked this website to see if it has updated, but I was quite dismayed to find out that their transgender resource and referral on the Virginia Department of Health website is listed under disease prevention, which I imagine is because someone was thinking about transgender identity as being a risk factor for HIV in men who have sex with men. So I think that is why it is under there. I'm hopeful if somebody would like to check that has been updated. There's also diversityrichmond.org, which has some other local supports. For children and teens, Side by Side is a great resource. They have groups, they have other sorts of supports as well. Professional resources, I mentioned WPATH, which is the World Professional Organization for Transgender Health. They pulled together, again, standards of care. If one is working with kids in the community or teenagers who identify as non-gender conforming, genderqueer, or trans, CHORE has a transgender care clinic. You just have to call CHORE and ask to get connected, and it's a endocrinology, and it was with Susan Jones, who used to work with us, but she's now at the Chesterfield County Community Services Board to help people navigate all of these things, all these different steps, because they can be pretty complicated for people. So this last part we can go ahead and do. I have like 2 minutes, but I will just, they were previously sort of cases to kind of talk about, but I'll just kind of run through them pretty quickly. So Danielis and Tillingeter said that the integration of one's identity across all aspects of self, including sexuality and gender, is a lifelong process. So it's kind of like lifelong learning. It's constantly changing, and that's okay. Identity development is understood to be a process driven by biological, social, and psychological forces, and gender, like sexuality, cannot be fully integrated and understood before the child or adolescent has the cognitive and emotional capacity to understand him or her or themselves. So this is all part of development. If you think about sort of stages of, Ericksonian development, if you don't know who Erickson is, you can look him up. He's great. Teenagers, prepubertal, like sort of pubertal on teenagers and young adults. It's a sort of individuation and identity is the big task of development. And this is just another piece of that. So just a couple cases, and I'll talk about kind of what the answers would be. So a 16-year-old white assigned female at birth individual who presents as male, uses a male name, male pronouns, has been on puberty blockers since age 13, has a number of psychiatric diagnoses, including depression, anxiety, conduct disorder, history of self-harm, drug use, anger outbursts. He's just a wild child. Does not consistently use a binder and is in a heterosexual relationship as a male. His therapist feels that the patient has some ambivalence about his affirmed gender. But at this time, the patient's mother is requesting that they start cross-gender hormones. So in that particular case, I think the therapist is probably on the right track there, based on all the stuff that we just talked about. The person really, at the time of initiating that kind of treatment, you want them to have pretty much socially transitioned and have essentially accepted or sort of lived that truth for a goodly amount of time. This young person, they've been on pubertal blockers, so you would just keep them on pubertal blockers and sort of see where that gets you. Now, again, there are risks to doing that, but if they've been blockaded since 13, there's not a lot of, significant risk of waiting a little bit longer. Some people had asked me the last time I gave this talk, how to handle it if a patient's transitioning to male or a different gender identity, wants to be called by a different name than their birth name, but their family only acknowledges them as female, wants all staff to refer to them using their birth name and gender. I've added some other sites here, the Family Acceptance Project from San Francisco State University, Trans Youth Family Allies, and then PFLAG. So typically what we have done in practice is that we will call the child by their preferred name and use their preferred pronouns. Depending upon where they are in the process and how comfortable they are during this the hospitalization or during the visit with us working with the family to come to an understanding about their gender dysphoria and gender identity, we may continue to do that with the family if the child feels safe doing it. If they don't feel safe or they don't feel like their parents are going to be able to hear that, we will document accordingly. But it's a question of, again, asking the patient themselves what they really want rather than us deciding. 12-year-old assigned male at birth person presenting as female for nearly 1 year, diagnosed with high functioning autism, disclosed gender identity to her therapist after she developed increased depression with suicidal thoughts, history of being bullied. At this time, her parents support medical intervention if she's, quote, truly transgender, and they worry that she's identifying as female to resolve social isolation and does not understand the impact of transition. Having had some patients who are kind of in this similar sort of boat, they're 12, they haven't gone through puberty yet, we puberty block. It buys you time. And again, it's not a question of whether someone is, quote, truly transgender or not, but it's a good time to sort of, block and kind of see what happens. If it is not a true dysphoria about gender identity, if it's something else. And it could be complicated, it could be multiple things. But again, puberty blocking buys you some more time to help figure that out and help the kiddo figure that out. Almost done. Are there medications related to someone's gender transition that transgender patients may be taking that somebody should ask about that could interfere with other medications? So again, the WPATH standards of care has some information about that. With feminizing hormones, there is an increased risk of developing venous thrombosis, stroke, liver, gallbladder disease, and dyslipidemia. Now, with masculinizing hormones, there's an increased risk of polycythemia and weight gain. But typically, there's not a lot of interactions with medications as a rule. And just in closing, an inpatient I had, they aren't quite as recent as they were, but I think any of my recent patients would probably agree that, again, trying your hardest to use the correct pronouns. We will mess up. We do it all the time. Acknowledging the mistake and correcting yourself is okay. And most folks are pretty forgiving of that. And I think I'm at or over my time by 5 minutes. Thank you for your attention, and I'm happy to take questions.
Do you have any experiences with folks who have detransitioned?
Okay, and it's a good question. So people who have desisted. I haven't. I think, in psychiatry, we're probably dealing with a fairly self-selected population where if one is desisting, they may not pop up. I had an outpatient who was in her assigned female at birth. We went through a number of different pronouns. It was not even so much gender fluidity, where there was a period where I'm going to use she here in this case, appeared to have desisted. And then we went back and forth quite a bit. And at the time that I stopped seeing her because I finished my training, he was identifying as male. And that was a long discussion that we had. I was doing therapy with this young person. And there was a point where I think, I didn't want to invalidate that person's experience, but I had to acknowledge as a therapist, like, I'm having trouble knowing where we're going because we keep going in different directions. And I don't want to, again, invalidate your experience of your gender identity. I do want to make sure that the reason that for your identifying in this way or having such difficulty settling on your gender identity is not because you just don't like the kind of female body that you have, but that it's that I don't like having a female body. And that was what was inconsistent and I had a really hard time with. But this young person was able to tolerate that. So I think it's okay if you are working with somebody where there's some ambivalence or it's not totally clear or you're confused. I think it's okay to admit, I'm confused. I'm not sure quite how to make sense of this, and we don't have to make sense of it right now. It's I think talking about it and kind of having that discussion is probably the most important thing. Now, certainly, I think there are people who would wish for their children to detransition, but again, I haven't really seen that.